And now for today's lecture on postural instability, say that 3 times quickly, and falls and Parkinson's. Our speaker is Dr. William T. Dauer, the director of the Peter O'Donnell Jr. Brain Institute at UT Southwestern Medical Center here in Dallas. He is a neurologist acclaimed for his research into dystonia and Parkinson's, and we are honored to have him as our first speaker for this year's Parkinson's Lecture Series. Help me welcome Dr. William Dauer.
Well, welcome today, and thank you everyone for coming, both everyone who braved the vicious snows out there in North Texas, and as well as everyone who's following along at home. I just want to, before I start, I want to make just a couple comments. First of all, to the local folks, I just moved here about 6 months ago to begin my work at UT Southwestern, the Brain Institute. And to the folks in North Texas, I just want to say thank you for such an incredibly warm welcome. And it's a great, phenomenal community. And I know that we're going to do great things together here and with partners sort of around. I also just want to take a moment to talk about just a couple comments about the Parkinson Voice Project. I was talking to some folks before the program began. These types of efforts are incredibly important, and I'm so impressed by what I've seen here so far. And they're important for 2 reasons, at least 2 reasons. One is what y'all know about, which is the actual work being done to help the symptoms of Parkinson's, and in particular, for this group, the voice, the speech, and swallowing issues. And so obviously that's crucial, that's essential. Being heard is critical. And that actually segues into the second point. Beyond the specifics of what are being done in groups like this and others, is the important aspect of developing community amongst the patients and between the patients and caregivers, doctors, nurses, physical therapists, and everything, so that we as a whole community can speak out to others to make, we're talking about 7 million people worldwide. There's still a lot of people who don't understand what Parkinson's is, who maybe don't know about Parkinson's. It's not only the other members of the community at large, just so they have better understanding, but that also translates into funding agencies, whether it be the government or others, to help make them aware of what the issue is, and so we can get the help and the support that we need to do better for people with Parkinson's and related diseases. So I think I just really commend everyone who's here for being part of the community, for showing up, and to the Parkinson Voice Project, and Samantha in particular, for her vision. And I just think these kinds of efforts are so critical for not only helping people today, but also they're a key element of our goals for tomorrow. So the subject today is really gait and balance in Parkinson's. And so let me just kind of give you a brief overview of sort of how I'm going to structure this, so you kind of know the roadmap of where I'm going. What I'm going to do is try to really ground my comments in a patient-focused approach. And so I'm going to talk a little bit about just simple fundamentals of Parkinson first, just very sort of basic about Parkinson's and dopamine. And then I'm going to take us along a story of one patient and the different issues of gait and balance that occur at the different stages of Parkinson's disease. And throughout each of those, talk about what the different issues are, give you a little bit of a glimpse into sort of the mind of the neurologist, the movement disorder doctor who's caring for you, of a kind of the things that they're thinking about, just so you kind of better understand how we're thinking about things. And that also gives you sort of knowledge in terms of, having conversations with your doctor when you're there. And then after we kind of go through that sort of clinical journey, if you will, I'm going to transition a bit into one of the really most interesting ideas, and I think important ideas about the underlying biology, the things that are going on in the brain to cause the gait and the balance difficulties, and try to give you an idea of what's happening and why we don't have now a therapy that is as effective or as what we would hope for. So those are the goals for today, and then at the end there'll definitely be time for us to talk if you have questions, and we'll go from there. So our journey begins, as I said, a very sort of patient-focused patient-centered focus. So this is a sort of a typical scenario that would happen early and someone that would show up in the office. So this is a mid-50s gentleman who has had some right hand shaking that's sort of distracting him during meetings. He's still functioning, he's still doing everything, but he sort of notices when he's not paying attention, his hand starts shaking. His wife is complaining that he can't keep up on their walks, and his friends have asked, why does he look so serious all the time, right? And so this is a kind of a typical story of the sort of earliest stages of Parkinson's. And many of you here may recognize these symptoms. The way we think about these symptoms as neurologists are these sort of what we call these cardinal features, or these main features of the illness. So obviously this gentleman has a tremor. The tremor in Parkinson's disease is typically what we call a rest tremor. And so that means a tremor that when you're not paying attention and your hand is just kind of at rest, starts up. It's not the kind of tremor typically, although it can be, and sometimes, where when you're using the arm. So classic Parkinson tremor is it's there at rest, and when you actually begin to move your arm, in fact, it may stop, actually. So although tremor is the thing that so many people kind of know about Parkinson's, in many cases, not all, there's some variation, but in many cases it's not the thing that's really disabling, because often it does go away when you're actually using the arm. Rigidity is another kind of fancy word for stiffness. So the doctor, all of you have been to the doctor and who have Parkinson's will notice the doctor does things like this, is moving your limbs about, and what they're looking for is to see whether there's a little resistance of a particular type that kind of goes with Parkinson's. Probably the hallmark of Parkinson is this so-called akinesia or bradykinesia, and that basically means either lack of movement or slowed movement. So slowed movement is really the most distinctive feature of Parkinson's. And so, for example, in that gentleman whose friends think that he's looking so serious all the time, it's not that he's feeling serious, but his face may move less than what he normally does. He doesn't have that normal expression and what we call the sort of so-called poker face. And so people sort of view that as, hey, what's the matter? And the person feels fine. There's nothing the matter. But it's actually, we kind of realize that our facial expressions are such an important part of communication, and that when they don't kind of happen automatically, it sends sort of different signals. So that's a way to say it's not, and he also obviously had trouble keeping up with his wife and walking. So there's slowness of walking, but slowness doesn't only mean about movement, it also means, like I said, the facial expression. Sometimes people have a little excess saliva. They may be involuntarily not swallowing as rapidly, so that's another way that slowness may manifest, or difficulty getting out of a chair. We don't normally think of that as slowness, but it actually is, in a way, the inability of the brain to kind of rapidly activate all the muscles that you need to get up. So what I'm saying is that slowness is really comes out in a lot of different ways. And even the voice problems to a certain degree, although it's complex, but to a certain degree, it's, if you want to project your voice, you need to, the diaphragm has to kind of be activated quickly to kind of push the air out. And to a certain extent, the low voice, or what we call hypophonia early in Parkinson's, is also a manifestation or a sign of this slowness. So slowness is actually kind of comes out with many faces, okay? And then what the aspect that we're going to focus on today as we go forward is this issue of postural instability and gait difficulties. And I will say, and I'll say this many times, this is not something that is typical or characteristic early in typical Parkinson's disease. And we'll go through this, but if it comes on early, it makes us think of some Parkinson-related disorders, and we'll talk just a little bit about that today. This is just to say that for those who want, this is what I kind of teach the residents and fellows. We try to remember these key symptoms by the mnemonic TRAP: tremor, rigidity, akinesia, and postural instability. Okay. So when we initially see a patient with these kinds of symptoms, we think about many different causes. We don't just automatically say, oh, this is Parkinson's disease, and this is going to be important to think about. What those symptoms really mean to the neurologist is that the chemical dopamine, which you've probably all heard about, there isn't enough, or it's not working enough in a particular part of the brain that's involved in movement, what we call the striatum. But there are many other causes other than Parkinson's disease that can also cause a problem with dopamine in that part of the brain. And I'm not going to kind of go through these extensively, but first of all, I alluded to, and we'll talk about these as we go on, these other Parkinson-type syndromes. So there's other illnesses that also affect that movement part of the brain, but they have distinct features, a different natural history, and it's important, in the initial thing we're always thinking about is this sort of typical Parkinson's, this is one of these other illnesses. There are other things, even trauma or small strokes in some case over a period of time can cause Parkinson's. That's why often early in the illness, sometimes doctors will get MRI scans and things like that just to make sure they understand what's going on. But what I actually want to talk about, which isn't a huge topic for today, but kind of it will help us frame the issue of gait and balance, is this drug-induced Parkinson's. So what is drug-induced Parkinson's, and why am I bringing that up today? So the kinds of drugs that can cause Parkinson, now they don't cause Parkinson disease, they cause a Parkinson-like picture, are any drugs that block the chemical dopamine, that prevent it from doing its action. And typically these are drugs that are used in either in psychiatric practice, so drugs that are used when people have sort of typically in schizophrenia and related diseases, so-called antipsychotics, but also importantly, drugs that are used to treat nausea and stomach problems. So metoclopramide is Reglan, and there's promethazine. So all of these types of drugs, on occasion, if you're taking them, they can block the effect of dopamine, so they kind of end up mimicking the Parkinson-like thing. Now, I'm not trying to say this is common, but these are something we always kind of check on the list in case someone's on. It can look indistinguishable from Parkinson's disease. And the good thing about these is if we find them, we take the patient off. And in many cases, not all, but in most cases, over a period of months, people can get better, right? So it's a chemical mimic, if you will. The reason I bring that up is these people don't typically have gait and balance problems, and they typically get better. And that just sort of makes the point that dopamine problems, and what I'm showing you here, and I'll explain in a minute, is the loss of dopamine neurons, which is really the classic aspect of Parkinson's disease, the classic pathology. That's what really had been the focus for over 100 years in terms of the pathology of Parkinson's disease, meaning what is the cause? The real early cause of this slowness and stiffness and low voice and these sorts of things is the loss of these dopamine neurons. And so what we're looking at here is a part of the brain called the brainstem, the substantia nigra, for those of you, some of you may know about this. And typically the dopamine neurons live in these two strips here, these brown strips called the substantia nigra. And it's brown because they have those cells, the dopamine neurons, have a pigment in them that's brown. And then you can see here that you don't have nearly as much brown as you do here. And so that's because the cells are degenerating, they're lost. So Parkinson's disease is what we call a neurodegenerative disease, and a major focus of the research is to try to understand why those cells die and how to prevent them from dying or how to slow that process. Now, if we think about the natural history of the illness over a long period of time, early on, the symptoms are very well treated with dopamine replacement drugs or drugs that modulate dopamine. So Sinemet or levodopa is the most common one. There are all kinds of other drugs that relate to the dopamine system. And early on, the slowness and the stiffness and these sorts of symptoms are treated because dopamine is the main player. It's the main problem that's causing the symptoms, and so we can do better with it. But what happens over time is patients may, not everyone, and there's a lot of variability, but over time you may develop, people may develop dopamine-resistant symptoms. And that means the development of symptoms that we just can't treat with dopamine or deep brain stimulation, which we'll talk about. They are something different. They're in a different realm. And it's been very difficult to understand those. And there's now as we've done so much better on learning how to deal with the dopamine-related problems with drugs, with deep brain stimulation, now our focus is a little bit shifting to how do we tackle these other problems that we're really not able to treat effectively now with medications. And gait and balance is one of the cardinal aspects of that. That's one of the key ones that's very frustrating for us as clinicians and obviously for you all as patients who have this problem to do better. Okay, and so that's really what I'm going to focus on today. I'll just say we're not going to talk about that today, but the other symptom that is really dopamine resistant and very frustrating for us, and related to a certain extent, actually related somewhat closely to this, as we'll see, is cognitive decline, and actually in some cases frank dementia that can accompany Parkinson's disease. So this is just another way of showing you about when these gait and balance problems begin, by using this so-called staging system that was developed, decades ago, but is still kind of a handy way to think about the disease. And so, it's stage 1 through 5. And initially, when symptoms are just on one side of the body, it's stage 1, and then it becomes 2. But you could see here, stage 3 is when you begin to have these impaired postural reflexes. And what that means is when your doctor kind of gives you a little tug back and kind of tests how well you can recover your balance, that's what they're looking for. How well can you recover your balance versus are you taking many steps back when they pull you? And then they're looking for that sign. And that, when one begins to have impaired postural reflexes, then that can progress over time to more and more severe, and in some cases, and we see here, some walkers and so forth, that sometimes you need help, whether it be a walker or a wheelchair in order to be safe. And this is a really important point in the progression of the illness. So what I'm showing you here is a graph, and down here, it's the different stages, those so-called Hone and Yahr stage. And here is a sort of quality of life scale, and so as it goes up, actually quality of life is less good. And so what we see is when you begin to develop one begins to develop postural instability, that really is a point where quality of life, as given by questionnaires, takes a hit. And it makes sense because before those things happen, the dopamine, the levodopa, these different medications are able to really effectively help symptoms. You're able to get around and do most things. But if there's some limitation of being able to move and get around and do things, that obviously has an impact on quality of life in a pretty fundamental way. So it's a very important problem that there's increased focus on, and also because it has a lot of impact and what we call morbidity on illness. So, patients with Parkinson's are at a really increased rate of fall if you look at the whole group, and an increased rate of hip fracture, which obviously is a bad outcome. So it's a very, very important problem that we need to do better on. So what I want to do now is, just having introduced the thing, let's trace the development of these gait and balance disease disorders or symptoms, and see a little bit how they begin, how they progress, and what the neurologist is thinking about, and what are the right things to be thinking about to do better at the different stages of the illness, and then we'll talk about the science. So starting with Mrs. W, a 62-year-old woman diagnosed with Parkinson's a few years earlier, and she comes in complaining of some brief episodes of imbalance. One day she fell back on her bed, but otherwise she's fine, okay? This is a very typical kind of symptom in, 3, 4, 5 years of Parkinson's disease. I mean, Parkinson's is very, what we call heterogeneous, meaning very variable. So I don't want you to take home like at 3 years, I'm going to get this. It's not the case. I mean, you may not get it for 10 years, okay? So there's not an inevitability here, but I'm trying to give you a kind of average picture of things. At this point, when someone who is doing otherwise well on medicine and has a bit of instability, this may or may not require any modification of treatment. And let me just tell you sort of what the things are that are typical at this early stage beyond that. So gait slowing, and we talked about that in the very first slide, is one, probably the earliest manifestation, earliest sign of some issue with gait, okay? The other thing is, and this is going to be an important theme, is this susceptibility to distractions, right? So that if you're walking along and you kind of start focusing on other things in your environment, you might feel, not that you're going to fall, but start to feel a little bit, a little imbalance, okay? So this idea of attention and walking and the interaction, you're going to see is going to be a big important theme, both in terms of things to think about to try to reduce the risk of fall, but also in the science of what we're talking about. Early on, there may be some falls, but that's not a typical prominent feature of typical Parkinson's. And this is the important thing. Early on, as I said, to the extent there are issues, often they're Cinemet responsive, whereas there may be, and it depends on the individual situation, but it may be, hey, your Cinemet is a little bit lower than we'd like it, or if you're on dopamine agonist, where we can kind of optimize the medicine, and you might feel a little bit better. It depends on your examination and so forth, but that's a common type of situation. So what do we do? I mean, so I alluded to, so optimizing Cinemet, or it's not only Cinemet, you may be on other, there's many other dopamine-related medicines, but there's a lot. That's one consideration, because often at an early stage, these kind of mild symptoms can be responsive. And as I said, to a certain extent, sometimes they won't be. Sometimes there's not a need to change the medicine. It's always a sort of balance in terms of all the other things going on. But the key is it's at least often in a responsive zone. I think this is also a time, and which is really, this is always the case, in my view, in Parkinson's, for exercise. So I put on LSVT Big, which is one sort of known national program. There are others, but there are other types of exercise. There's boxing for Parkinson's. There's Tai Chi. There's the Wii game. There's a Wii game where you just kind of balance on the board and it's kind of a thing. So there's dancing. I know that My mentor, Stan Fawn, for a long time used to talk to his patients about how he and his wife liked to square dance, and that's another thing. Whatever it is, if you're doing, what's common to all of these things is you're engaging the body's balance centers, so to speak, and training them. And it's important to remember that even in Parkinson, what's the key thing that we all know about the brain that's different about the liver or the heart? That it learns, right? We know the brain learns. It can change with experience. And to a certain extent, when you're doing these exercises that engage the balance centers and sort of you're training them, it's not going to stop things necessarily, but you can sort of counteract it and try to be as good as you can be. So as I always tell patients, if you think that the illness is going to take a certain percentage away, well, if you start higher up, even if it takes that same amount away, you're going to end up in a better state. So I don't mean extreme exercise. I don't mean Olympic exercise. I mean something that's reasonable several times a week that involves the sort of this kind of balance centers, again, whether it be any of these sorts of things. And even walking is probably good. Now, there's no real evidence that one is better than the other. It's a matter of being engaged. So these are the kinds of things we think about early and the kinds of therapeutic ideas we have. Now, let me just take a moment to say, just by way of education, general education, I mentioned that significant falling is really not typically a feature of what we call idiopathic Parkinson's disease or typical Parkinson's disease. So if someone has symptoms just for, a couple years and is already having significant walking problems and falling, we as neurologists, and if that's happening to you and you haven't talked about neurologists, sometimes you need to think about, are there other things going on other than kind of typical Parkinson's disease? So, let me go back. One of the things that might be going on in that case that we think about is these sort of what we call Parkinson plus diseases or these Parkinson-related diseases. These illnesses, and you can see the long, what I call alphabet soup, MSA and PSP, and there's others. These illnesses do affect the Parkinson-related areas, but they also prominently affect other areas, and so they're important to diagnose because they have a bit of a different history, and it prompts a different type of discussion with the physician. There are other illnesses, sometimes something called hydrocephalus or high pressure in the brain, in some cases can mimic a kind of Parkinson that primarily affects the legs but not the arms. So people who are really, really very much stuck to the ground early on can have something like this. What we call white matter lesions, what that means is some people who have a lot of high blood pressure, diabetes, who may smoke, these kinds of risk factors for vascular disease and may have many, many small strokes. They don't necessarily have a big stroke that they knew about it, but when you look on the MRI scan, they may have that. And then there's always a very critical thing, which is medications. So benzodiazepines are like Valium or Valium-like medicines. Tricyclics are like things like amitriptyline. These are sometimes prescribed for sleep. They can have effects on the brain that if one has Parkinson's, may be sensitive to it, and it may kind of tip you over the balance and promote to a certain extent gait and balance problems. And so these are the kinds of things we think about. And I just put that in there sort of for general education. So if things are happening early, you're kind of aware. And this is just to show you a couple features of this so-called PSP, or progressive supranuclear palsy, which is this Parkinson look-alike. Patients like that typically have this sort of stare, like this kind of like what they call an astonished look. And the reason why, for those of you who have been to a neurologist with a Parkinson-related complaint, the reason neurologists often look carefully at your eye movements is because patients with this illness, PSP, will have difficulty with their eye movements that typical Parkinson patients don't have. And so I'll show you an example here. This woman is being asked to look over here to the side, and she can do that just very well. but now she's going to be asked to look up and down, and you'll see that really not much happens. I mean, the sound is off, but basically she's being asked to look up now, and now she's being asked to look down, and it's very, very difficult for her to do that. So that's a kind of thing that, just to kind of let you understand why we look at the eye movements, because that starts to tell us about this may be a different type of illness. Okay. So let's continue on. So several years later, the same woman, Mrs. W, returns, and now she's had a couple falls. She broke her wrist. And at times her feet get stuck to the ground, and she may feel frozen. And other times of the day, she feels perfectly fine. So now what we're into is what we call this middle stage of Parkinson gait. So the middle stage, this is two key things, or others, but the two sort of things that may happen is something called gait freezing, and as well as something called festinating gait. So gait freezing is this issue of the feet getting stuck to the ground. So this is particularly, and I'll show you some videos as an example, but particularly when you initiate gait, meaning when you start going, you kind of can't get it moving, and then once you get moving, you're off to the races. So that's one kind of gait problem that happens in the middle phase. And this festinating gait can be where, as I say here, tendency to move forward with increasing but smaller steps, so just kind of following over the center of gravity. That's another kind of thing that can happen in this middle stage. Now, to a certain extent, and again, not all patients this is the case, but definitely one important consideration of these sorts of problems, especially like, again, this patient, Mrs. W, was fine sometimes, but not fine at other times. It can be that this entering of this middle phase of the illness, where instead of being in what we call that honeymoon phase, where when you take a medicine, you're kind of fine all the time, now your symptoms more are tracked to the timing of your medicine. So you take the medicine and you start to feel good. You feel good for maybe a few hours, 3 or 4 hours, but then you start to feel it wear off. And it's during those wearing off times where you may have this frozen difficulty moving, difficulty with gait, and with not just with gait, with other things. And that's shown here in a sort of a diagram. So this is the blood levels of, in this case, levodopa or Cinemet. So you see, you take it. You want to be in this sort of yellow zone in order to have good motor function. But when you go up, early on, you go up. But as the disease progresses, this sort of safety zone, this yellow zone, shrinks. And so now you start to, when you're in this red danger zone, you don't have enough of the medicine. And so that may lead to slowness, stiffness, and these kind of freezing and walking difficulties that are problematic. And we're not going to talk about it today, but I saw you had previous talk about dyskinesias or extra movements. So that also can happen when you're on the other end, when you're too high. So this is a big consideration. This kind of fluctuation is a very common thing that the movement disorder neurologists will work with. And let me just show you some examples of the freezing, just kind of this will help, I think, educate you, and also if you're having this, it'll help you talk to your doctor about it and let them know. So this gentleman is going to be come up and going to be asked to turn around. So turning is a very common time when people will get freezing as well. And so here he is walking fine. Now he's going to be asked to stop, and now he's asked to turn around, and he's trying, and you see what's happening here. He's basically getting stuck and having he's trying to turn, he's just getting stuck. And you see that characteristic, his legs are moving back and forth. Now the video stopped. Okay, but that's a kind of typical freezing episode, and it may be not as dramatic as that. Sometimes when people turn, it might be, this sort of thing, but it's something to be aware of, and we'll talk about that a little bit more as we go along. Here's another gentleman. This is in a laboratory, and this illustrates another type of situation where freezing may happen. It may happen when people are going through sort of constrained spaces, things like doorways in a kitchen, and we'll talk about a little bit about this when we get into the science. So this gentleman is going to be asked to walk, and he's got a little bit of difficulty walking here. His feet don't come too up, but when he goes between these two things, you see what happens. He really kind of gets stuck. But then once he gets through it, or it may end, I can't remember. There he goes, and he gets better. So that's a very classic type of freezing that happens as you're going through doorways or other tight physical constraints. The other interesting thing, and it'll again get to, I'm putting it up here and keep it in mind when we get to the science, it's going to be important, is sometimes engaging your attention system, again, here's this attention theme, can help overcome these gait problems. Now, sometimes this can be helpful as a therapeutic, a little bit. It's not typically, a really robust therapy, but it's something that we see in the office typically. It's something that so you see these stripes now on the floor, okay? They're just pieces of tape. And now we're going to see this same gentleman and how he can walk. So now he gets up. And by sort of engaging his attention on that, look what he's able to do compared to what he was doing, if you remember what he was doing the last time. Again, it's not really possible to have stripes all over the world but sometimes that kind of thing can be helpful in certain situations, and it relates a little bit to how we think about these kinds of problems, which we'll get to as we go further. So let's talk about this middle stage. One thing is always we think about what can we help, right? Optimizing, not just Cinemet, I have Cinemet here, but there's let's call it your dopamine regimen. There are a lot of, and it's not worth going into the sort of the weeds of that, but there are many things that the Parkinson doctor can do to try to keep you in that yellow zone that I talked about. So that involves changing different formulations of Cinemet. It involves using what's called dopamine agonists, different medications. There are many different things that can be done to try to, get the dopamine level in a zone where you're not falling into that danger zone or up into that other high zone, and that's an important aspect in this middle phase of the disease. We'll come back to DBS in a minute. As always, make sure there's no other medicines. Has there been anything else new that's happened? We always want to make sure about that. The best thing happens in the doctor's office, the most happy I ever am, is I can help someone by taking away a medicine. There's no better thing than that. Reducing to the extent constraints in the physical environment. What that means is, hey, are there areas of your house where you're constantly having to go through tiny little areas? Just the way the house is set up, are there ways to move things around or to spend more of your time in an area that's a little bit more open and not, especially if you're getting difficulties in those. So that's something that's important, as we saw in that man getting stuck through the doorway. Low tech, but critical. Get rid of loose rugs. So this isn't so much about freezing as it's an easy way to trip, because if you're not picking up your feet, you're going to be more likely to trip. And then there's a lot about also stress itself is definitely linked to provoking these sort of freezing and falling. This kind of getting really kind of trying to rush and being stressed, that can provoke these episodes, not just in a way of being nervous in a general way like we all are at times, but we actually believe that there are aspects of the brain circuitry that when you're sort of in a high level of stress, this is more likely to happen. Now, whenever I talk about stress, I always tell patients, you can't make zero stress in your life. And if you do, you'll be really stressed because it's just not a possible solution, okay? So we all have stress in our lives. We all have things that happen. So you have to be reasonable about what you do. But I think it's at least worth thinking about, and this relates to, I didn't have that on there, sort of planning your day. To a certain extent, when this is a problem, the more you can kind of be aware of planning your day and know what's going to come, what the events are, just have things a bit more predictable. It can help somewhat with these issues. And sometimes when people fall, they actually, understandably, develop a real serious fear of falling, which is, again, totally understandable. But that fear itself can lead to a lot of stress and anxiety to the point where it kind of takes on a life of its own and can contribute to this. And so if that's something that we all have to be aware of, and there are ways to, through different cognitive therapies and being made aware of it and physical therapy to help reduce that. Now, I want to say that in most of these cases, there is going to be these things are going to make the issue go away, but they can help it, and they can help reduce the risk of falls, which is what we always want to do. We want to do prevention because once a fall happens that has a significant injury, we're obviously much less better at getting you back to where you were, and we really want to prevent things. Another thing I have out here, another thing I didn't put up here that I want to say that I always tell patients is, in addition to the rugs, that when you get up at night to go to the restroom, have some kind of light. You don't have to turn the lights on full blast to kind of wake you up, but some kind of night light or something, so you're not. I don't want anyone walking in the dark, anyone with Parkinson, because that's just going to increase the risk of falls. And also having something up, especially in a bathroom, a bar of some sort, not a towel bar that's going to come right off the wall, but an actual bar. If you don't use it, that's great, but if you have to use it, it's great that it's there, especially in the bathroom, because tile floors are really unforgiving. So, let me go back, actually. So deep brain stimulation. So when someone has these fluctuations, that and this middle stage, that's a pretty common time where depending on a particular situation, deep brain stimulation is commonly thought of and is an appropriate thing to think of. And I'm not going to get into that because you've had whole talks about that, but I just want to say that is an important component, and it's been a big boon, in my opinion, in the last 20 years to really help and improve the quality of life of patients in this middle stage of the illness. But deep brain stimulation, as important and good and as groundbreaking as it is, and I really do think it is, and we hope there's even more for it in the future, it obviously is not stopping the progression of the illness. And within 10 years or so after deep brain stimulation, a lot of people are going to have gait and balance problems. And that is because the disease is going on. And so that gets into sort of what we call the advanced phase of Parkinson's. So in the advanced phase, really, the gait and the imbalance is just not responsive to any medications that we have, unfortunately. This phase, people with significant gait and balance disease in the advanced disease will frequently, again, not always, these are general statements, have cognitive decline. And it's very important, as we see here, and I'm glad to see from a safety perspective that people do this, to transition either to a walker, a wheelchair, and to really, it's important, we always want to improve or maximize quality of life, not just to say, okay, I'm going to sit around, I can't do anything, but to really get out there to an occupational therapist, working with your family, friends. How can we come up with a new set of new ways to accomplish things that bring meaning and importance and value to life? And it requires some thinking and some creativity, but one can refashion what they do and how they do it. And occupational therapists, many of them are really, really outstanding at this. And so I think it's very important. I always want my patients to be out there doing things to the extent that they can, because I think activity, interaction, those things I think are important to maximize quality of life with the illness. So it's we're not giving up. So the question is, and we're going to sort of transition now into the sort of underlying science of this illness. Why is this happening? Why is it that early on in the illness, we're able to kind of take care of things, but then as the illness progresses, we're getting into things that we really can't take care of from a pharmacologic standpoint. So in order to talk about that, let me now just focus in on gait and balance and sort of when do these problems happen. So as I've alluded to here, this is a woman in her kitchen, and I do that because so many of my patients will say, it's when I'm in my kitchen, I sort of fall over, I'm imbalanced, might fall. And think about what's going on in a kitchen. I always think it's such a useful thing to think about. First of all, you're distracted. She's making something. You're doing this, you're doing that. Thinking, what's the next thing I'm going to add? So you're not thinking about your walking, or you're kind of distracted. The other thing is you're in between the island and the counter, and you're turning, right? You're turning back and forth. Get this from the fridge, back and forth. So there's a lot of turning, there's a lot of constrained space, and there's a lot of distraction. And so these are primo things that we see in many cases, and they're a clue, as we'll see, to what's going on. Now, I'm not telling people not to work in their kitchen. Keep making good cookies and food and all that sort of stuff, or whatever you do. But this is a way but it is something to be aware of. And it gives us a little bit of a clue to what's going on. So it gets into this idea that's really central to some of the thinking about walking issues, is this idea of attention and gait. Now, when I walk along this podium, you probably think I don't feel like I'm having to pay any attention to my gait. It just happens automatically. It turns out that if you do experiments in the lab where you have people who don't have Parkinson's just walking along, and then you actually ask them to do things like subtract 7 from 100 and keep going down, or do whatever kind of cognitive test. If you look at their walking during that, what you actually see is their walking changes. Okay? So even in normal people, it's very clear from there's hundreds of these studies, that if your attention is being taken by some other task, your walking changes. Now, in a normal person, you're able to obviously stay up. But we see, and what's also very clear in patients from a variety of illnesses, including Parkinson's, whose walking is a little bit impaired, if you now do the same task in them, their walking goes down, their ability goes down much more. So it's as if, and I want to put this out there, there's a certain amount of attention out there, and in a case of a normal patient, if you kind of reduce it, the walking might change a little, but you still have a lot left of attention. But if you start down here, and now you kind of reduce it, now you're kind of getting into a danger zone of not having that normal attention that we don't really think about typically, but is important in walking. Because walking and moving in general is not just the brain saying, move left, right. Actually, what the brain is also doing is taking in all the things that are going on around, so this attention, so it can do the right things. And that includes that if you move your foot a little bit in the wrong way, maybe partly subconsciously, but being aware on some level that it's up and making a correction. But if you don't have enough, if your brain can't attend to it, now you can't correct, right? And so we all know about this. So this is maybe appropriate for this North Texas day, the snow. This is kind of a Michigan slide, but right? So if you're walking on ice, or, let's say it's after dinner and it's it's dark, you're walking a gravel parking lot, you're looking for your keys, you're kind of aware, right? Right away, you're like, you're kind of focusing your attention, because when your gait is when you're on a little bit unsteady, you have to kind of focus more attention in order to maintain your gait and do the right thing. And it's this impairment of attentional capacity in Parkinson, and we'll get to the reason, that is an important aspect, not the only thing, it's a complex thing, but it's an important aspect of what's going on here. So let's talk about this. So one of the things that's important to understand, and really wasn't focused on for the longest time, because before there was Cinemet, patients, they didn't live as long. They didn't do, we didn't do it. But now, as we do better and better and better with therapy, and people do better for much longer, we're starting to see the other elements of the illness that come out. And one of the things is the PD, or Parkinson neurodegeneration, is widespread. So over time, it does spread. It's not just a dopamine disease. It spreads to other parts of the brain that use different chemicals, right? So dopamine is one chemical the brain uses to signal, but then there are other chemicals that the brain uses for different parts of it. And in particular, for the attention part, it uses a chemical, or what we call a neurotransmitter, called acetylcholine. The name isn't really important, but we call that system cholinergic. It's just a different chemical than dopamine. And it's very important in the body, the brain's ability to have its focus attention. And so when there's a loss of that cholinergic ability from this degeneration spreading, together with the dopamine deficiency, that is in an important way contributing to the gait problem. And let's get into this just a little bit. I won't get too far down into the weeds, but I think it's important to understand. I'm actually going to skip this slide. So let me tell you about the the so-called cholinergic pathways of the brain, the parts of the brain that use this other chemical, acetylcholine. So there are two main pathways, so to speak. There's one here I have listed as BF, which is the basal forebrain. So that's a part, this is critical to what we've been talking about. So that these cells live down here, but they send their sort of what we call projections, and they go all the way out to all parts of the cortex, the thinking part of the brain. And this pathway is critical for attention, for attentional, the ability to focus attention. I don't know whose thing is going. I don't think it's mine. Okay, I don't have anything on me. And this is these nerve cells clearly do degenerate in Parkinson's over time. And as we'll see, their degeneration is linked to the progression of these gait and balance disorders. Then there's a separate set of nerve cells down here in what's called the brain stem. So this is an MRI of someone. So I should have told you the nose is here, the back of the head is here, and this is as if they were slicing me down the middle and looking from the side. And so this PPN has a long, complicated thing called pedunculopontine nucleus. It's not important, but you may hear about it because there have been some trials about putting deep brain stimulating electrodes in here, which in my view haven't been successful. But this is another set of these cholinergic neurons, and they project in many different directions, up here to something called the thalamus and back here to something called the cerebellum, which is very important in gait and balance, okay? And this also degenerates in Parkinson's. So what I think was a very, very important paper, and there are many, but I'm just going to show you one, is linking the cholinergic system to gait and balance disorders. So let me decipher this slide for you. So history of falls associated with reduced cholinergic activity. This is this Nico Bonin, who's a colleague of mine when I was up at University of Michigan, who's really a pioneer in this field. And what Nico did is he looked at Parkinson patients before they had gait and balance difficulties. Well, a group that did and didn't have gait and balance disorder. And he did two types of brain imaging studies on them. One is he used a brain imaging study that allows you to look at the dopamine neurons, how many are there, the integrity of that system, which is the typical kind of thing. But then the other thing he did is he used a different kind of strategy to look at these cholinergic neurons. Okay, using a tracer or a kind of chemical that had not really been used so much before in Parkinson's disease. And what he found is no change in striatal VMAT. What that means is, to decipher, means the amount of dopamine problem in the people who were or were not falling was not different, okay? So they had a similar degree of dopamine problem. So the gait and balance problem wasn't that the dopamine degeneration was more. What was really different in these patients is, and again, don't worry about these abbreviations, the cortex and the thalamus, different areas of the brain, including ones that are implicated in attention, had reduced cholinergic integrity, right? So that was really an early finding, and there are many other papers to sort of get to this idea that it's not just the dopamine, but when you have these other systems start to come into play and you begin to lose them, that is, the combination is kind of causing the problem. And that also makes sense for, why aren't these just treated with dopamine? Well, they're not treated with dopamine because dopamine's not the only part to play here, okay? Now, something that is really wonderful and important for you all to know about. This is something called, this is an image of the brain, and don't worry about the details, but what you can see, what's important here is you see all these kind of red and light yellow and green, and here these different colors. This was a novel compound that was, the compound wasn't discovered at University of Michigan, but while I was there, we kind of got it to kind of go into patients and Parkinson's. And without getting into the details, what's really exciting about this is it's a much, much better way to look at these cholinergic nerve cells. The resolution is much better, and you can see much more detail. So this is really allowing researchers, not just that can do it, and I'm aiming to bring this down to UT Southwestern as well, to do ever better research to understand what are the different parts, where's the key element of this cholinergic system that might relate to gait and balance difficulty and other aspects of Parkinson's. So it's almost, we're still doing all the research on dopamine, but we're realizing now that there's these other parts that are really important. And I should say that these cholinergic systems, these attentional systems, are also heavily implicated in the cognitive problems of Parkinson. And that's why we really believe now why the cognitive and the gait tend to go together, okay? And this is just showing, just giving you, came out, I think, last year, and I'm not going to get into the details, but just to kind of show you how using this new compound, new ideas are happening, new things are being discovered. My colleagues and I published this paper in the Annals of Neurology, and so I want to give, I think, justifiable hope that we're really kind of on the track now of this and really looking. Just briefly to kind of highlight, and then we'll get into just a few more slides, to highlight how we're thinking about this. It's more complicated than this, but I think this gives a good schema, if you will, of how we're thinking about it. So what happens is we sort of develop this kind of model of gait dysfunction. So early on in the disease, you lose dopamine, okay? And dopamine is very important for things like habits and automatic movements. And so when you lose some dopamine, basically, habitual means automatic, basically. You know, the walking isn't so automatic. Many of you with Parkinson's probably have experienced, like, I have to kind of think more about what I'm doing, right? It's not just without thinking. And so you're able to kind of do okay early in the disease in terms of gait and balance by increasing your attention. Okay, well, this may be a little more less automatic, but now I can kind of, okay, I'll just focus a little more as if I'm in a gravel driveway, and I'm able to do okay, right? So in a way, even though you may not be aware of it, bringing more attention onto what you're doing allows you to kind of compensate for the other problem. That makes sense. But then this sort of hit two, this loss of basal forebrain cholinergic neurons, fancy way of saying, hey, when these cholinergic cells that are important in attention begin to get hit by the illness, well, now you don't have this much attention of the brain ability. You might just have this much, right? And so you're not able to, it's kind of getting the rug pulled out from under you. You're not as able to compensate for it, and you start to have gait and balance problems. And then these other cholinergic neurons start to go, and over time it progresses. And so what we really need is to better understand the sort of interaction between these different problems, which are the key, and develop new therapies based on this understanding. And we're on the way to that. I'll mention something at the end. Actually, let me go back here. I just want to say that as a result of this, and this is getting just in the last few slides of the sort of the science of it so you can see, what we've started to do, we meaning the whole community, is to try to develop new ideas and new models for how do we study this in the lab? How are you going to study this balance and gait problems in the lab? And so innovative researcher developed a model of this problem by causing dopamine neuron problem in a rat brain, but then also a cholinergic problem to see whether that putting those together would lead to a kind of gait and balance problem. I mean, they don't really have upright gait like us, but sort of that type of problem, a problem of balance and walking related to attention. So let me just show you what he did. So here's a normal rat, and they're walking along this rotating beam, which is very, very difficult to do, and you see that it's able to do it really well, okay? So this is, don't worry, this is with the dopamine and the cholinergic problem together. So you see the rat does really well, and now it gets to this so-called doorway, boom. So, and don't worry, there's a net underneath, by the way. So, but what's important is when the attention is taxed, the movement goes down. And actually, there's a lot of studies showing in this that the degree to which the attention is impaired is also related to the degree to which the movement is impaired. So the brain doesn't work just by, there's a movement area and attention area. Everything talks to each other. I think this is obviously most critical for Parkinson, but it's actually something more important for the brain in general. We're not, it's telling us a little bit more how the brain is working. And then I told you about these other parts of the brain, cholinergic system that go actually to this cerebellum, this part that's important in balance, and also the vestibular system, which is involved in balance. And it's key about falls and turning that most tasks in the home require many turns. A lot of the falls happen during turns. When a fall happens during a turn, it's more likely to result in an injury. And you see that, that turning is a really common risk factor for falls. Now, again, just like stress, you're not going to stop turning. You can't eliminate it. But I would say the practical advice is the following. In addition to all the things that I talked about rugs and things like that, which I think are really important, it's just when you're doing things, if you're in these, if a patient is in these, certainly in these middle and later stages, when you're doing things, try to focus on one thing at a time and not have a lot of distractions. Now, again, this isn't going to be a cure-all by any means, but we're just trying to minimize the risk, right? It's all about prevention. So if you're doing one task in the kitchen, well, then you don't need to be talking to the person in the other room or have the TV on. You just focus on focusing on the task, or maybe you're walking and not so much talking and just kind of focusing on what you're doing. If you're kind of feeling a little bit unsteady, having the attention distracted is just going to make things that much more difficult. And the turning, to the extent, again, you can only do this to a certain extent. I mean, I don't want to create more stress by saying, we're not going to live on a tennis court with nothing there. You got to have a room, you got to have a doorway. But to the extent might be modifiable things where you're not doing so many quick turns and things like that, that could help reduce things. Let me end on a positive note. It turns out that there are medications available that boost up cholinergic signaling, right? They're kind of, in a way that levodopa boosts up dopamine. There are others that can help either boost up acetylcholine, that chemical, or help to mimic it. And there have been a couple studies, one actually reasonably sized, to look at using these medications. And again, this rivastigmine, and I forget which one this was, but these are medications that are actually out on the market for Alzheimer's originally, but also for Parkinson's, for cognition, for thinking. As I told you, again, there's that link between thinking and movement. And so the idea is, hey, if they're helping for one, might they help for the other? And these are early days, okay? So I'm not kind of saying go out there and get your doctor to prescribe you this, but it's something to be aware of. It could be helpful. We need a lot more data and evidence. We need bigger trials. But I hope that I've shown you, and then this is where we'll end, that even though the problem it's an important problem and it's a troubling problem, but I hope that I've shown you that there's a real clear direction here. There's new thinking, there's new tools, there's new models. Progress is being made, and there's already the beginnings of some thinking about how to do that. We're going to need to do a lot more. It's a little more complicated than this, but I think it hopefully gave you a good idea. So with that, I just want to also thank you again for your attention, and I'm happy to answer any questions.
Okay, thank you, Dr. Dauer. So we're going to start the Q&A. We'll bring the microphone to you, and if you would please speak with intent and hold the microphone close to you. We have one on this side of the room and here, and we'll take turns.
Okay, thank you for an excellent lecture. Very informative. I have a little bit of a mixed-up problem in that I've gone 2 years now, and I'm not even certain I have a full dosage of Parkinson's, which may be attributed to what you mentioned that I'd never really heard of before, was medically induced Parkinson's. Is it possible to get over medically induced Parkinson's? And how do you do it? Just by eliminating the medicines that you're taking?
Okay, so... I have, right, of course, yeah. I forgot, okay. All right, thank you. Okay, let me repeat the question. The question is, if someone has medically induced Parkinson's, or what we hopefully would call it drug-induced, hopefully the medical establishment, although doctors prescribe the medicine typically, but what we would call drug-induced Parkinson's, can that be overcome just by removing the medicine? So again, let me review a couple things. So there are common drugs like Compazine, Reglan, which are taken for nausea, which can block the ability of dopamine to do its work and can cause a Parkinson-like syndrome. There are other medicines which are more for in the psychiatric realm, what we call antipsychotics. There are a range of them, but sometimes those are given for sleep and so forth. So that's another class of medicine. So whatever the offending agent, if someone is on these medicines and they don't need, now some people just need to be on them. If someone, for example, if someone has schizophrenia and just needs to be on these medicines, sometimes there's not much you can do, and you just kind of, they have a little bit of these Parkinson-like symptoms, but overall, what's the best thing for the patient? Okay, but that's clearly not the case here. So the issue is what happens. So if the potentially offending medication can be removed, you remove it. Okay. Now, what happens when you remove it? Now, in many cases, one does get better. Okay. Now, for reasons we don't understand, it can take months. It can take up to 6 or more months to kind of get back to know what the degree of improvement. Now, we don't really understand why it takes so long, but it does. It can, okay? So you can't make a decision after a week or a month. You really need to just stay off them for, I would say, 6 months to kind of see what's going on. Now, having said that, and that's certainly what we would always do, not everyone who gets taken off the medicine does go back. A considerable number of patients continue to have Parkinson's symptoms. And why is that? Does the drug cause the Parkinson? Okay. We don't know for sure, but we don't think so. So let me explain a little bit. What we know broadly in neurodegenerative disease now, Parkinson, Alzheimer, that as we gain an ability to look into the brain with these advanced neuroimaging technologies and other things, we see by the time you come to the doctor with a complaint, you've actually had things going on for several years at least, okay? Maybe more. I mean, actually, anyway, many years. So during that time, the process is kind of kicking along, and in Parkinson's, the dopamine neurons are being lost, but the rest of your brain is able to kind of compensate in whatever way it does, and so you just don't recognize anything until it kind of gets to a critical point where you... So imagine you're not at that symptomatic stage, but you're 50% of the way there, and now you take a medicine which kind of drops you down. So you might be more susceptible. You do have sort of emerging Parkinson, but when you impair the system a little bit more, now you're going to be more likely to show it from the medicine, whereas someone who didn't have that wouldn't. Let me give you an example. The classic thing is a cardiac stress test. You can walk around and not have chest pain, but if your cardiologist puts you on the treadmill, now you're having your heart work more. So you can basically, it's like a stress test for your brain if you take these medicines. That means that some people, when we take away the medicine, end up still having the symptoms because actually what the medicine did is just show us a little earlier what was going to happen. So there's no way to know. I think what's important is no matter what, in my opinion, there's zero way to know, no matter what your symptoms look like or your brain imaging or anything. The only way to really know is to try and take off the medicine and see what happens, because drug-induced Parkinson can look like identical to typical Parkinson. So I think to answer really directly to you, the way to know is to take away the medicine and see. And I obviously can't make a specific suggestion to you without knowing a lot of other details, but that would be the general approach. Okay.
We have a question on this side.
We participated last year in a drug study for Eli Lilly, and this drug study is called Presence, and it was very helpful with the cognitive. It was stage 2. Do you know anything about this study, and what is the status of it now?
What was the name of it?
Presence.
I apologize, but I don't know that specific. I mean, there are a lot of studies going. I don't know about that specific study. The only thing that I would say is that, just in relation to what we're talking about here, if it's about cognition, it may relate to this, gait imbalance as well, even if that's not their main focus. But I can try to find out that for you if you just come up to me after. I'm sorry, I don't know that. Yeah.
Okay, thank you.
Yeah.
All right, we have a question over here.
Hello. Thank you so much for your time. Oh, right here.
Okay. Hi.
Thank you so much for your time and your lecture today. Oh, that's cool. So you had mentioned like how attention helps with gait, especially in Parkinson's disease, and there's like a lot of other symptoms as well. So do you suppose is it a possibility that thinking about or putting attention on other symptoms could also alleviate and help treat those symptoms as well?
I mean, I think that very much is true, can happen, and I think the challenge is, the reality is, it's just very difficult to consciously think about what you're doing at all times. So I might ask Samantha to comment on this, because I just want to say that I think to a certain extent, very much what Samantha what's being done here in Parkinson Voice Project is related to what we're talking about. So do you want to comment a little bit?
Oh, absolutely. When we focus, when we're deliberate and purposeful, definitely the speech and the swallowing can be improved. And when people are walking with intent, opening the car door, riding with intent, I always tell people, imagine you're filling out a wedding invitation. It's really important, concentrate. But it's hard to do that 24/7.
Exactly.
And that's where these groups and the loud crowd come into play, because you get that support to continue strengthening the muscles to stay strong, but then also getting tips to focus your attention on it. And I want to mention, I don't know if our loud crowd has noticed, but our flooring at Parkinson Voice Project, we specifically in the Education Center have these diagonal lines going through, and throughout the clinic we've got the carpet tiles, alternating carpet tiles, and the doors to our group rooms are all double doors. And we did that purposefully when the building was designed.
Right.
But
And
yes.
I think that that's just tremendous. I think I completely agree with this, and both for the positive side of it and for the challenge that you did. But that, I think, also highlights really my opening comments, that the community, whether that be this broad community, whether it be your family and friends, it's impossible to do it 24 hours a day. But to the extent that you can be in situations that are comfortable, that where people are aware of, the issues and can help you be intentional, as Samantha said, that really that can help quite a lot. I'll just also say that there are these amazing stories of patients with Parkinson's. You may have heard them, and I used to think they're apocryphal, meaning they're not really true, but they really are true. That in Oliver Sacks' first book, Awakenings, you can read about them, where patients in certain situations, so the classic is Parkinson patient in a burning building who can suddenly just run out. The soccer player who was really kind of frozen, and then you throw a ball. I have videos of this. You throw a ball to them, and suddenly they can activate a movement program. So we're really trying to, part of what this research is in a much larger sense is trying to understand, how there are motor programs, if you will, locked in there. How do we release them? And right now, I think the most important way that we have is these intentional strategies, these cueing, whether it be lines, whether it be the community. That's one way that's helping. But that idea of attention and movement and things like that, are there other ways we can sort of learn from these, brain imaging studies to do that? That's kind of what we're shooting for. And hopefully that will be successful.
We have a question on this side. Oh, online.
Yeah, we have two questions from online. The first one is from PH, asked, would ADHD meds help with Parkinson's disease?
So ADHD medicines typically are more related to sort of amphetamine-like drugs, so they're really more of a dopamine-related. So while I can't say in any specific case, in general, that's not the type of thing that would help. What I would think would help gait and balance. They do help alertness. It's a little bit more. There's a little fine line between alertness and attention. So certainly, if somebody's not alert, that's kind of dangerous time to be walking. But in general, we don't give those medicines to patients.
And then Kathy asked, can you have Parkinson's but not have the chromosome for Parkinson's? Can you explain that?
Yeah. So the question is, when you have Parkinson but you don't have the chromosome for Parkinson's, can I explain that? Okay. So this is a general question about genetics and Parkinson's. So there's been a real revolution, and I also want to emphasize how important this is for the future. There's been a real revolution in the thinking about Parkinson's disease in the last 20 years. Let's see. I did my neurology residency from 1993 to 1996, not too long ago. The textbook at that time, the great textbook coming from Columbia University authorities said, and I have a slide of this, that there's basically no genetic cause of Parkinson's. Fast forward to 2020, or even 15 years ago, we know that that's not true. So in that period of time, there is well over 20, and actually way more than that, but at least 20 genes that have been implicated in the risk for Parkinson's disease. Now, let's be clear, it's complicated. Some of them are what we will call strong genes, meaning it can be passed from generation to generation, okay? That's relatively uncommon and a small percentage of the overall population. There are a couple of somewhat notable, somewhat exceptions. So there's a LRRK2 gene, a LRRK2 gene, and this what's called a GBA gene, glucocerebrosidase gene, which in some populations, including Ashkenazi Jewish population, are somewhat more represented and may actually represent as much as 10 to 20% of that population. But for most people, there's not a what we call Mendelian or strong effect gene. For most people, they have little tiny, small little changes in their DNA that when you add all the 20 or 30 of them up together, they just increase risk somewhat. But there's not a test for that. It's more of just a risk thing. So most people really with Parkinson's disease don't have a gene that we can say that's the one. We believe that, again, there's some degree of risk there, that there may be little small changes that many people with those changes wouldn't get it, but there may be an element of the environment and other things during your life that combined together may kind of tip you over to the balance, but we don't have a specific test for that. So it's actually, just to conclude, it's actually most common for people with Parkinson's not to have a defined big gene problem. And for a lot of people, for most people with the disease, we're still working on understanding what were the determinants, and it's probably not one thing, it's probably a bunch of little things put together. What were the determinants that push that person into the Parkinson zone, if you will? Just I will conclude by saying that one cannot overemphasize the importance of these genetic discoveries. Now, what they aren't is a cure-all. What they haven't done is really helped anyone yet, okay? So, but they're the hope for the future, or one of the hopes for the future. What do I mean by that? When a researcher has a gene, that enables a whole variety of scientific studies to be done that there's no way to do without the gene. It's a clue to really what's happening in human beings with the illness. It's something that caused the illness in the patient. And I would say that although most patients don't have one of these strong gene mutations or errors, some of these genes, in particular one called alpha-synuclein, even though only a tiny number of patients in the world have that mutation that causes the disease, when you look in the brains of anyone who had the disease, they have accumulations and abnormalities in sort of how that protein is working. So what I'm trying to say is the gene mutations may happen in only a few, but they're giving us clues to what's going on in the many, okay? And that's really what's underlied so much progress. So this is the type of thing, and UT Southwestern is world famous for this, rightly so, the idea of how cholesterol works, all these cholesterol-reducing drugs, that all started from Brown and Goldstein here, who are Nobel laureates, studying very, very, very rare patients with mutations, but then that gave a clue to the sort of wider picture. And that's our hope for Parkinson's, but the work continues. And one of the things that we're really going to be doing at the Brain Institute here at UT Southwestern is trying to catalyze that type of research as much as we can, as well as clinical research and all types of other things. So
all right, we have a question over here.
Yes. Hello. Thank you for your presentation. I was recently diagnosed with Parkinson's, and I wanted to know what the effects of being under anesthesia might have had on my diagnosis. I was under anesthesia for 7 or 8 hours for spinal fusion, and I wanted to know what do you know about that effects?
So can I ask, so the question is what the effects of anesthesia may have been on Parkinson. And so just let me ask one question. No, just fine. Was that, after being on anesthesia, was that the first time you were diagnosed, or did you already have Parkinson's before you were on?
No, after the surgery, after the anesthesia.
That's when you noticed the Parkinson?
That's when, a few months after that. A
few months after, okay.
Yes.
Okay.
And I was diagnosed with Parkinson's.
Yeah, okay. So what is the relationship between this anesthesia and Parkinson's? And so, first of all, what I would say is your story is one that we've heard before. I've heard from patients. I've had patients who have surgery and then they kind of wake up and they notice a tremor in the recovery room and they say, hey, did the surgery cause the Parkinson's? Our feeling at this time, as best as we understand, is the answer to that question is no, meaning we do not believe that surgery or anesthesia or so forth, so long as there's not a big complication, just kind of typical surgery, we do not believe that that causes it. What we think is, and not that we fully understand it, is it's similar to kind of what I was talking about with the drug-induced Parkinson, where there's some number of people out there, we know since there's years of what we call pre-symptomatic Parkinson, where things are happening in the brain, that when you're, if you're kind of at that edge where you're, maybe someone's going to have symptoms in 6 months, and then they go under surgery, and it is a bit of a stress to the brain, and it just may kind of reveal, because, sort of what's been there a little earlier than might have been otherwise. Now, how that happens, the kind of mechanism, we don't really understand, but it's something we definitely have seen on occasion, okay? So it's tricky because, again, this so-called pre-symptomatic phase, where there's some things going on in the brain for many years, and then suddenly something happens, and of course, it's natural for you to think about that because it's close in time, but I think it's very, very, I would tell you if you were my patient, I think it's extremely unlikely. I don't think that would have caused it. I think, might you have gotten your symptoms, 3 months later? It's possible, but that's sort of how we think about it. I hope that's helpful. Yeah.
Unfortunately, we are already out of time, and I know we have a lot of questions online and here. I want to thank you, Dr. Dauer, for being here. Let's give him a round of applause.